This conversation is for men and women. I just sat down with Dr. Marsha Nunley to talk about some of the biggest questions surrounding hormone health after 40. What's the difference between hormone pills, patches, and pellets? Can women who've had breast cancer or are on hormone blockers even consider hormone therapy? And most interesting, men over 50, do they need testosterone and DHEA? Find out with this interview. I think you're going to find it fascinating. Dr. Nunley, how are you today?
I'm fine. How are you?
I'm well, thank you. There are so many forms of hormone therapy out there. Patches, pills, creams, injections, pellets. What is the biggest difference between them and what differentiates them and what are the pros and the cons?
Well, basically, everything you've just described, it's a delivery system. So are you delivering the medication into the bloodstream by skin absorption, by oral, by pellet insertion is where you actually make a tiny incision and insert the pellet under the skin. Creams are absorbed, patches are absorbed. So those are the major differences. And just one of the things that one of the reasons for that is they have different effects when you do these different delivery systems. Essentially, a patch and the pellets are the same. They're going, and creams, that's transcutaneously. Mm-hmm. So the biggest difference is really whether it's patch or pill or pellet or pill. So.
Okay, so who is a candidate for the patch, the pellet, or the pills? Like what differentiates that? Like when you speak with a patient, how do you determine who gets what?
Okay, well, let's just start with the pellets. So the pellets have actually been around a long time, and they were actually FDA approved for women who had had a hysterectomy, but they weren't very popular, I think, and I guess they were used in some women who had had a hysterectomy, but they didn't really become mainstream for women. So the pellets have become a little more mainstream utilized, but you have to go in and see your doctor about every 3 months, and you get a little, numb it up, a little injection. So it's a little bit of an invasive procedure. And once the pellet is in there, you can't take it out. So that better be the right dose. And you base it on weight, but sometimes it's not enough. Sometimes it's too much. And so it's difficult to adjust. You have to wait a full 3 months to adjust it. So that's the pellet. Oral estrogen has been around the longest. That's really what what we started off with. And that primarily has been Premarin, which is it's synthesized from pregnant mare's urine. So it's different from what you take, but it's been around a long time, been used in a lot of the studies. So a lot of the benefits that we see were actually women on Premarin. Now, women who take an oral pellets, whatever. Well, if you have a uterus, you have to take progesterone. And in all the literature, they talk about progestogens, and that is synthetic progesterone. So it's not the same, and it's different, and it has different results. But those are the main oral ones. It's Premarin and Provera, and now mostly we do estradiol and bioidentical or micronized progesterone. Progesterone is a very large molecule, so it can be really difficult to absorb. So it's hard to give progesterone subcutaneously. You'd really have to give it orally. So that's kind of the main differences in those. And one of the things I would just say is that, so Premarin is, again, pregnant mares, and that can be patented. That's a drug. It can be patented. It can go through the whole process, and they can, charge whatever. So it's a moneymaker because it can be patented. Estradiol, progesterone, testosterone, those are all natural substances. You cannot patent a natural substance. So what they do is they patent the delivery system. So the oral estrogen has a specific delivery system to get through the gut. The patch has a specific delivery system. That is what's patented, and that's why those are drugs.
Got it.
Okay. So
what are the benefits? So I'm on pill form, as you know, since you're my doctor, and it's working very well. But I actually was speaking with some friends over the weekend. I have a friend that had cancer and she's on hormonal blockers. So because all I do is tell everyone they have to call you and get on some hormone therapy. And she said, well, I can't because I'm on hormone blockers. So what do you do in an instance when you get a patient that, is concerned about heart health and all these different benefits that being on hormone replacement does, but yet they're on hormone blockers? What does one do?
Well, so the hormone blockers are part of the treatment for breast cancer. Okay.
Hmm.
So, and that's like, there's a shifting sand there, but basically a woman gets breast cancer, and there's different types of breast cancers. There's different stages. There's different ways these are managed, but let's just say that this is a woman who had a localized breast cancer. She had a lumpectomy. She possibly had radiation. If she had a lymph node, it also depends on the type of cancer. They can now really get it down to a very detailed account of what that cancer is. Like, for one thing, they can tell how aggressive it is. Is it a cancer they measure the division time of these tumors. So some of them are really dividing fast, and that's higher grade. Some of them are kind of slow. They're just kind of really low grade tumors. So all that matters in how they treat her, whether she gets radiation, chemotherapy, and then the receptor status. That means they look at the receptors on the tumors, and there's estrogen receptor, progesterone receptor, and then there's what's called HER2, herpresine, I forget the name of it. Anyway, it's a HER2, it's another receptor, and they target those receptors in the treatment. So she is probably somewhere a few years out from breast cancer and is taking the hormone blockers. So there's the current regimen, I would say recommendation is that women can take hormones even if they have breast cancer, but the current recommendation is to go through the treatment. So let's say she takes hormone blockers for 2 years or 5 years.
I think she mentioned 5 years she's on hormone blockers.
So that's generally what they do, is 5 years. And again, depends on the stage where they were. But at the end of that 5 years, she can, and it's something she decides. If she feels fine on them, she's doing fine, they may recommend she take them 10 years. They just tend to extend it out. But the current consensus is that after 5 years for treatment, women can go on hormone therapy.
Interesting. But it has to be after the 5 years. It can't
general,
be.
Yes, the recommendation is after the 5 years. Now, I have some women who sort of, the data, there's a guy, his name is Blooming, Bluming, Avram Blooming, Bluming. He wrote a book called Estrogen Matters. He's a medical oncologist, treated primarily breast cancer patients. His wife had breast cancer, and he's now retired. And I was kind of looking up just to see what he was doing. And he's got a whole bunch of YouTube videos and things. And so he wrote this book back in 2013, I think, and it came out in support of hormone therapy for women with breast cancer. And way back in the 50s, when all this kind of started, we didn't know anything. They just sort of did whatever. They were, giving women mastectomies, and so things change over time. And they really didn't know what they were doing. The early treatments for breast cancer was estrogen. They gave high doses of estrogen because what does it do? It blocks the estrogen receptors, right? So there's controversy. There's still, it's accepted that those receptors are important in treatment. And if they look at treatment, they will see and they have these big graphs and statistics, or it can be really confusing, but they will show that women who took hormones or take hormones have a slightly lower incidence of breast cancer recurrence. So let's say way they look at the statistics, there's a 1 means that's where you start as 1. So if it's less than 1, it's a slightly better, and greater than 1, slightly worse. So in looking at, this was a meta-analysis, which is where they take a whole bunch of studies and look at them. So they looked at women who had breast cancer and women who, they looked at breast cancer recurrence. Okay. And after women who took the hormone blockers or whatever had a slightly decreased recurrence around, it was like 0.9, 0.8, somewhere in there. However, they had a higher risk or incidence of morbidity and mortality from cardiovascular disease, dementias, bone diseases, and so there, it was a bit of a trade-off. It wasn't like, oh, this is great. And actually only 10 to 25% of women actually survive these it actually do improve on these blockers and stuff. So it's a mixed bag, really. And there's just and the data is so jumbled up. And because a lot of it's on Premarin, a lot of it's on progestogen, some of it's progesterone, estradiol. So it's hard to say. But I would say this guy, Blooming, he did a study over, it was like 14 years, I think. He took women in his practice. He tried to get FDA approval to look at women who had breast cancer and took hormones. He wanted to do that. They would not approve it because there was just so much stuff around it. So he did that, and his study ended like around, I think, 2006. So he was before the Women's Health Initiative, and the Women's Health Initiative is what caused all this big hoopla around this. Because if you, and here's, I guess, what I was getting to about medicine. Medicine changes. And so we start back in the dark ages when they're doing mastectomies, taking all the nodes, everything they can remove, they would do that. And that's how breast cancer was treated. Well, then sort of over time, they started to realize that women weren't living longer with that. They were just, dying horribly with these terrible, what am I trying to say? These terrible surgeries that were just so scarring. So they kind of made it past that. And then into the next ones, they started doing just the single mastectomies. Well, actually, over time, they began to see that, lumpectomy types, a certain type, size, all that was just as effective as mastectomy. So that's why, but doctors were making a lot of money. Surgeons there were surgeons who were doing multiple mastectomies. And so they didn't want to change their practice. So they didn't believe it for a while. It takes a while for this stuff to kind of shift through. So that I've mentioned that just because of the whole hormones and breast cancer thing. I think that's kind of where we are, even though there's lots of data that says hormones do not increase the risk for breast cancer. There's something like Blooming said there's like 14 studies that gave women who had breast cancer hormones, they had no increased risk for recurrence.
So what does a woman do if she's had cancer and she's on these blockers, but yet she's concerned about all the other benefits that you receive from being on the hormones? What does she do? Or what do you do with the patient that comes to you that is on the hormone blockers?
Well, I would say, honestly, 50% or more of women do not tolerate them. They're very difficult to take.
Oh, interesting.
A lot of side effects. So frequently, a woman will come to me because the problem is doctors they won't even talk to women about hormones. I have a friend who has an oncologist, and she didn't have much of a tumor and all this stuff. And the doctor would not even talk to her. She said, I would consider that malpractice. She said, no, hormones, no, absolutely not. But there are doctors that understand, but where they are, that's not that's not the end all be all. So what I do with someone who would come to me and I sort of look at, are you tolerating these hormone blockers? How you feel? How's your life? And if they're like, it's miserable, I just seem to be dead, then I'm like, okay, well, let's talk about what we could do. We can talk about stopping them. Do we want to give you hormones? Here's what the data shows. But it's not written in stone. And I kind of telling you those stories about how medicine changes. I think changing now towards hormone therapy is that's beneficial in so many ways. Why would you deny women who have had breast cancer all these benefits when the risk is minuscule, if any? So I would sit down with someone, and that's what I would do. I would talk about, first of all, how symptomatic are you? Because I'm not going to jump in and say, oh, your doctor's wrong or whatever, because they're basing it on what their data tells them. And,
Right.
and they haven't, they have not advanced past, and I think that's happening slowly. But your typical oncologist doesn't really read much about hormones. They don't any more than they read about cardiovascular issues. So they have a very narrow focus. Anyway, I think I would just sit down with mama and just talk to her. How are you feeling? What do you want to do? Here's your issues. I need to know what kind of tumor you had, what kind of treatments you had. How long have you had hormone blockers? How did you tolerate them? Are you going to just stop everything? Are you going? What are you going to do? So where are you in that whole conundrum? And then try and come up with a plan that fits that. And for some women, it is hormones. For some women, they take hormones. But, as a physician, there are many physicians, they're very fearful of malpractice, and because it's not an accepted thing now. Now, Blooming is now retired, so he's out there, promoting and preaching and all that. But in the hormone courses we go to, they talk about, you have to be very careful. You cannot promise women these things because medicine changes. It it was okay 50 years ago and then it went away 25. Now we've come, when the Women's Health Initiative came out, we came full circle back to hormones are bad. So anyway, that's what I would do is you got to just sit down and have a conversation and with someone. If you can get an oncologist that is knowledgeable, great. But if you can't, then you can talk to some of the hormone doctors. A lot of them, well, I don't know how many honestly follow the whole breast cancer thing, because I would say the majority of doctors are just like, no, I'm not. You've had breast cancer, no, because they're afraid of lawsuits, they're afraid of whatever. So if you can find someone that will talk to you and listen to you and consider hormone therapy for you, if your doctor and you deem that is the best thing for you. I mean, I had one woman and she was like, okay. And it also, like I said, depends on what treatments they had, but she had a double mastectomy. Okay. And she didn't have a whole lot of tumor, but she didn't want one boob. She's like, okay, so they can have double mastectomy, reconstruction, whatever. But she was like 62 and she said, if they want me to take hormone blockers for at least 5 years and then maybe 10 years, I'm going to be 72. I don't want to go through my life for 10 years with, because she went off the hormones when she was diagnosed. She said, I don't want to go through that. I don't want the rest of my life to be like that. So, for her, it was just a really different situation. And she was like, I understand the risk. I'll sign any and all stuff you want me to. But for me, right now matters the most. My life, I want to live my life now. So
it sounds super complicated for a woman. It's not straight. This situation is not straightforward at all. And it doesn't sound like the patient has much support from the oncology doctor, working with the hormone doctor. And I think that's what's frustrating for women, to feel that they don't have the support. Also, are these hormone blockers, is that used just for breast cancer? Do they do that, or do they do that with other cancers as well?
Well, one of the things that no, they do not. The HER2, they may use that for Herceptin, it's called. There may be some other tumors that express these markers, the Herceptin markers in particular, I can't remember. But in general, estrogen, progesterone, no. The estrogen blockers are used in breast cancer only. In fact, early on, that was one of the things they were doing when a woman had breast cancer. They, especially if she was a young woman, she was premenopausal, they would remove the ovaries because they thought, okay, that's, we got to get rid of all the estrogen coming around. Well, it turns out that didn't make any difference, did not influence recurrence at all. So they no longer do that, I hope. And so yeah, that's really the only ones. There was something else I forgot I was going to say, but anyway, no, they don't use these blockers for anything other than to block estrogen.
Who is an ideal candidate for patches, pills, pellets, creams, injections? So you mentioned earlier that the pellets are typically for women that have had a hysterectomy. What about the patches, the pills, the creams, and the injections? Who are the candidates for those?
Okay, so let's just start with the patches, because the patches have been found to be there. There's a history of estrogen and increased risk for blood clots. Those are venous blood clots, by the way. But birth control pills and Premarin and progestins in particular in an oral form. So the patches were to get around that. And so basically they are a bioidentical estradiol, not Premarin or Provera, and they're go through the skin, and they do not have any risk for cardiovascular disease, clots. So I would say, someone who's had a hysterectomy, if they want to just go every 3 months and get the pellets and be done with it, that's fine. I would say that's fine. It just makes it much easier to manage rather than, if they've had a uterus. So, woman with a hysterectomy, yes. A woman that is let's say, why would you use pills, right? Because actually, most of the studies done way back when we had all this positive benefits of hormones was done using Premarin and Provera, and the Women's Health Initiative turned that on its head. But the oral estrogen is where the benefits of cardiovascular issues, the benefits of dementia, cognition, nervous system, the benefits of bone health. So those more systemic, metabolic, when you take an oral estrogen, it goes through the liver and it gets metabolized to these, they're called matrix metalloproteinases, and they are responsible for some of this stuff with the cardiovascular system, the bones. They upgrade the bony formation, so that, because women lose bone after estrogen. So that's kind of patches, pills, and then the injectables. Most women don't want to do injections. I don't have anybody that wants injections other than testosterone. We might do that in women, but most of them. I remember a long time ago, my mother used an estrogen injection, but she'd had like a hysterectomy, ovarectomy.
So typically when you're getting a woman's hormones balanced, it is always the progesterone, the testosterone, the estrogen, and what's the other one? The
DHEA.
DHEA. Those are always taken together. Do you ever omit one, or? Because I know I have all of those, but are there some people that don't need those?
Yes. So those are, I would say, not studied particularly. The DHEA and even testosterone is not particularly studied in women. So your typical, and it's the estrogen that they worry about. So the breast cancer, all this stuff, it's not the DHEA, it's not the testosterone. They're a little edgy about, but it's the estrogen that makes a difference. So many women, let's say they just go and get hormones, they'll get put on estrogen and progesterone by their doctor, and that's it. And they don't really check levels. They give them a standard dose, and you're good to go. So I'm from a little bit different school. We look at it a little bit differently. DHEAs are very important. It's an androgen. It's important in immune function, in aging. Seems to just help with aging. And then testosterone in women has just really been overlooked, but it's really important. It's important cognitively, mental health wise, as well as DHEA and muscle mass. So those are all important. And so in the schools where I have most studied, we manage all of that rather than just estrogen and progesterone. But if you go to your doctor, probably you're just going to get estrogen and progesterone.
Correct. Okay, so let's bring back in the supplements because we discussed that last time. How important with these hormones are the supplements? Because we did a hormone, we obviously did a hormone panel on my blood, and then you did a really interesting panel on my vitamin, how I was receiving it. How important are vitamins and supplements with hormone balance?
Well, so again, in traditional medical literature, you will not find much about vitamins. Vitamins, supplements are kind of frowned on. And I did not realize the power of supplements until I kind of went through my own issues. And some of these supplements are really make a difference for women.
Such as which ones? What are the most important ones?
Okay, so hormones first: estrogen, progesterone, DHEA. Now, are you calling that a supplement, or is that
no?
DHEA?
I count that into the hormone.
Okay. Well, I just wanted to clarify.
Yeah.
So estrogen, progesterone, DHEA, testosterone. That's good. So supplements. I always look at vitamin D. Vitamin D is associated. Vitamin D has a structure more like a hormone. So it's really part of it has a very similar structure, molecular structure. So I always look at that and always bring that up. I have, you think people get out in the sun, but I've only seen one person with a normal vitamin D, and she lived in Texas, worked on a ranch, and she had a vitamin D level of 70. And that's the highest I've ever seen. And most people come in with levels around 20 or 30 or even less. And vitamin D, it's important in skin, it's important in vision. I had one guy who had a vitamin D level of 2. He had ocular nerve swelling and was having vision problems. Put him on vitamin D, and within a few weeks, he was back to normal. So neurologically, a huge difference. Bones, of course, vitamin D is important. And so women who are going to lose bone as they age need vitamin D. So that's a big one. The other vitamins are, I always look at B12 and homocysteine. So B12 and folate are both B vitamins. And the B vitamins in general are important. Cognition, neurologic function. Like people who are alcoholics, they get what's called Wernicke's encephalopathy. So because their B vitamins because alcohol, they're all just used up, and they get this encephalopathy. This is something you learn in the emergency room as a physician, and you hang this bag of vitamins. It's the yellow bag, and you can look around and say, okay, you know what that guy's got because he's got the yellow bag hanging there, and his encephalopathy will clear. So we look at that. We look at and also folate. So a lot of people have a genetic SNP for folate, and they don't process it very well. So something like 40% of the population has that. It can interfere with pregnancies and all kinds of things. And so I don't always just check for the genetics, but if anyone has, a lot of B vitamin deficiencies, we might look. But that homocysteine is a test that we measure, and that's measuring a composite of B vitamins, because you need certain ones to complete this metabolic pathway that keeps your homocysteine in a good range. Elevated homocysteine is associated with cardiovascular disease risk and dementias and vascular and otherwise. But so that's the other big area that we look at for vitamins is all your B vitamins, and your homocysteine kind of measures the whole pathway. So
what other vitamins? We've talked about B's. What else? Omega, zinc.
Yeah, omegas.
Magnesium.
Omegas, of course, omega-3s. And omega-3 is going to help your skin. We have some data on omega-3s, but it's also kind of a mixed bag. But, skin, joint, anything that's lubricated, anything that's dry can be helped by that. And so I measure those because I usually only do it like once, but just sort of convince people to take their omegas because we don't eat enough fish. We really usually eat, even plants don't, you don't get chia seeds and walnuts are about the only thing that have some omegas. There's a few others, but they're not something we eat a lot. And then, so those are the main, so omegas, and then zinc, the minerals are really important. Zinc and copper are, again, in brain function. Those levels, they should be on a ratio of about 1-to-1. So I usually look at those. What else? Are there others? Can't think of any off the top of my head.
What about magnesium? What's
So
the importance of that?
Magnesium gets a lot of press, and that we don't take enough. It's a little difficult to measure because so your body says it will take it out of your bones or whatever to keep your serum magnesium normal. So it's hard to know if I just draw a blood draw. So you have to do like a red blood cell count or some of these tests, these nutritional tests that we did, we can do that. But yeah, I think, supposedly many people are magnesium deficient. It'll help with sleep, with relaxation, people who have muscle cramps, which is a lot. It's very calming. And there's different types of magnesium. There's some that's not very well absorbed, and that's the kind that magnesium oxide, and they gave it when I was in training. That's what we always gave, but you got to give it IV. It's not you just don't absorb it. So we have some that are better. The supplement companies are better.
Which is the best magnesium for someone to take that's, trying to get their hormones balanced? Which magnesium is best for that?
Magnesium glycinate at night to kind of help with sleep and all that. And then magnesium taurate in the mornings, which tends to be a little more, it's not going to do as much sleep-wise, but it's just going to help with, I guess, just with calming in general, but it's just supportive. And so glycinate at night and taurate in the morning. You could take just glycinate both times, really, but some people use the taurate seems to help with, cramping a little bit more and things like that.
Let's shift a little and talk about something that most people don't realize, that men's hormones actually matter. This is not just for women. So when a man is over 50, they come to you, and what are they coming to you for?
Well, when I first started, I was in San Francisco, and the men that I would get were usually young men in their 40s, maybe 50s, even 30s. But they have no energy. And their lifestyle's terrible. They sit around and they sit on their computers. They go out to eat. They drink. They eat too much. They're overweight. And so a lot of it is lifestyle that brings them in. Alcohol will really, you see men who drink, their testosterone, it impacts their testosterone. They stop producing as much. But that's kind of what I would see, would be younger men and then older men as well. But the younger men were the ones that kind of seemed the most interesting kind of, but you can, and increasing their testosterone and giving them DHEA does wonders. And then also and then they tend to feel better, and they might get in the gym. They might start doing, they're a little more amenable to lifestyle changes. Once they feel better. So
And how are they getting the testosterone? How do they get that in pill form, or is that an
Well,
injection?
it's an injection. So there is a pill form available, but it's inordinately expensive. Everyone was like, "Oh, now it comes in a pill. I want to try the pill." And I said, "Well, it's like 3,000 a month or something."
Oh my gosh.
So I don't
Something.
even really mention it. Mostly injections I do. They're once a week, and it's a pretty standard dose. Sometimes
Hmm.
a small man or a larger man may need more. Um, and then pellets can be very effective in men because it's testosterone, and they last longer. So they might
Oh,
be
interesting.
every
How long
4.
does it last for them?
May is some as much as 5 months, 4 to 5 months. Usually they can get by, but then I have some are like, no, I'm coming back every 3 months. Because they can feel it start to wane, and they'll
Mm.
be like, no. But it just the biggest thing is think about the grumpy old man. That in general, that's what they become at 35. So.
Is
Uh,
that when it goes down, the testosterone for men, the levels in the
yes.
30s? And so by the time they're 60, 65.
Well, men can have normal testosterone levels into their 70s, 80s, and beyond. They
Hmm.
do, they don't go through that decline like women do. What men We don't know why men's testosterone has been declining, but sort of looking at it worldwide, it probably has to do in part with pollution, in part with lifestyle. Men no longer work outside in the sun, and physical labor tends to increase your testosterone. So highest testosterone I ever saw was in an older man. The man was like in his 70s, and his testosterone was like 750, and you really
Wow.
see that. You'll see it in someone who's been a regular exerciser, really sort of, not just a little walks every now and then, but really dedicated to exercise. That really is very helpful for men with their testosterone. The other thing is in these young men, you can use a drug to stimulate the testes to make testosterone. And so
Oh, that's
that
interesting.
they don't have to take just it. But in older men, their testes are not able to produce that. So in general, with older men, you use testosterone creams. Men use creams. Creams or injections are generally what I do. I've had a few ask.
What about men that have had an alcohol problem in their past and not longer? Does that affect the testosterone, even if they're, have been sober for, 5 to 10 years? Are they affected by having had an alcohol or substance abuse
I
problem?
don't know that I can answer that. I've seen young men with low testosterone who had an alcohol problem, but I've not seen them for a long term to see whether it comes back or not.
Hmm. Hmm.
Um, because I don't know. So I don't know if that, but if someone's in their 50s or 60s, I would say probably need replacement.
So
Um,
are those the only two things that men typically need, or the testosterone and the DHEA?
DHEA. Well, the whole vitamin thing and all that, we look at all that. We look at cardiovascular issues and things like that. But typically, yeah, it's just those two, vitamin D and all of those others. But DHEA and testosterone are just the big two for men.
Interesting. Is there anything that I've missed today that you want to share?
Um, I guess I would just tell women particularly women who have breast cancer or have had breast cancer, and you're not feeling well, talk to someone. I think there's more and more, uh, and if I'll be happy to talk to anyone, but explore. If you're not where you want to be, then don't just suffer. I would say,
Right.
yeah.
I agree. I think the biggest takeaway from this conversation is you really have to be your best advocate. You know how your body feels. If you don't feel like if you feel like you're off, you are off. And if your doctor isn't giving you the right information or option, then explore speaking with someone like Dr. Nunley that is a hormone specialist for
Yeah.
men and women.
If they're
And
not interested in listening to you and sorting out your issues and problems, then you need to, you don't necessarily need to get rid of that doctor, but you need to explore other avenues for that, because it's just, women have suffered for too long. They really have.
agreed. And they
And
don't, and I hear all the time, oh, well, that's just aging. No, that's wrong.
no, it is not.
It's not acceptable at all.
No. So no, but I hope it was helpful, for someone sitting out there thinking, what should I do? And should I do nothing and just suffer through? And I would say no, because there are things also besides hormone that could be helpful. But honestly, nothing's going to work as well as estrogen. So
Yeah, absolutely.
yeah.
I can't thank you enough. All your info will be in the show notes, and I encourage
Thank
everyone.
you. I will be
figure
sure. Look here. This is Aubrey's book. It's called Estrogen Matters. I think he might have another one out, but it's really helpful to understand how we got where we are, and it helps you to understand that doctors aren't just bad. They make mistakes. That's kind of the way science works.
Right.
So,
but
anyway,
you can't expect an OBGYN to be a hormone expert. So
no.
you can't expect, and that's unfortunately that most women go to for this.
Yeah.
And they're given the progesterone and the estrogen, and they don't do the vitamin panels, which I think everyone in the world every year should have their vitamin panels done, because you don't know what your base is. We've talked about this before. I was taking all my vitamins every day, diligent, and I was totally malnourished. I was not taking enough of the ones that I wasn't taking enough omegas, and I wasn't taking enough D or zinc or, magnesium. So we may think that, we self-diagnose our vitamins, which is really a huge mistake. And I urge everyone to get their vitamin panels done besides their hormone levels. Dr. Nunley, thank you so much. You have so much knowledge.
Christina.
I'm so grateful. Have a great day.
It's been a pleasure to do this with you, and thank you.
No, thank you. I'm
Okay.
Christina Flach, and I'm too busy. I'll see you next week.